and we are experiencing a large volume of participants today, so it's just going to take a few more moments.
Okay, thank you, Ryan, for the update. Appreciate it. So for anybody just joining us, my name is Tia Briley. I am with the Washington State Hospital Association. We are in the process of assigning recording privileges to participants. It takes a moment or two to do this. And Ryan and Ashley, who are helping us with this, are going to let us know when they're ready.
And we are good on my end.
Okay, thanks, Ryan.
I'm good on my end too.
Okay, thanks a lot, Ashley. And again, good morning, everyone. Thank you for continuing to share this important story with our communities. My name is Tia Briley, and I'm the Executive Vice President of the Washington State Hospital Association. And I am joined today by panelists who represent hospitals from across the state, from small rural hospitals to large urban health centers. And I appreciate that each of them is taking time to be with us today. They are all faced with the monumental task of keeping our community health systems running during very challenging circumstances. And so we'll hear from each of them on their perspectives on the situation. Our panelists are Dr. Elizabeth Waco, who is the Chief Executive for Swedish First Hill, Reza Khalil, who is the Chief Executive of Kadlec Medical Center in Kennewick, Christina Wager, who is the Chief Operating Officer for Newport Hospital and Health Services, Dr. John McGuire, who's the Chief of the Division of Pediatric Critical Care Medicine at Seattle Children's Hospital, and Dr. Michael Anderson, who is the Chief Medical Officer for Virginia Mason Health. And before we turn it over to them for their views and comments, I would like to share a few words. And honestly, I wish it were better news. This is the worst situation hospitals in Washington State have been in compared to any prior point during the pandemic. We are experiencing a crisis across our medical system, and sadly, we've now just reached 1 million Washingtonians who have been infected with COVID-19. COVID-19 hospitalizations, which are currently at an average of 1,800 for the past week, have now exceeded our previous high of 1,700 in September of 2021. We've seen about a 65% increase in COVID-19 cases in the past week, and we've averaged 226 new COVID hospitalizations each day this past week, and roughly 12 to 20 COVID deaths. Of those in the hospital this past week, the average number of patients on a ventilator was 149, which was a 16% increase compared to last week's average of 129. There's also a significant shortage of staff and hospital beds. There are multiple factors that are converging to create this situation. And we're already in the midst of a sustained national staffing shortage. Similar to other job sectors, hospital staff are becoming infected with COVID-19 as a part of their daily lives, impacting their ability to work. And I would note that unlike other types of organizations, hospitals do not have the option to shut down operations. Just this morning, my daughter's school sent an announcement that the entire school was shut down due to sick staff and staff sick calls. Hospitals have to stay open to serve patients. They don't have this option. The surge of Omicron cases on top of hospitals already crowded with patients who do not need hospital care is creating terrible delays of care and backups. Currently, hospitals have stopped all non-urgent procedures. A procedure or a surgery will only be performed if not performing it will lead to patient harm. This massive backlog is within the control of key state leaders to address. Across our system, hospitals are caring for hundreds of patients who do not need to be there. They should be in nursing homes or other long-term care settings or at home with home care support. And those patients, if those patients were moved out, we would have adequate space and staff to manage the surge of COVID-19 patients with our existing hospital resources. We've spoken previously about the steps that we think are necessary to alleviate this bottleneck, but to quickly recap a few, the state needs to assess patients faster. It needs to pay nursing homes more so they can retain staff. They need to clearly communicate about the availability of state-supported units for COVID-positive long-term care patients and remove this nonsensical barrier that requires guardianship appointments prior to discharge for patients who can't make decisions for themselves, but have loving family members literally at their side. We've been in dialogue with state leaders about other measures in addition to these to alleviate this situation. These include potentially deploying the National Guard to perform non-clinical work, further augmenting hospital and nursing home staff with state-supported contract agency staff, and fixing this guardianship challenge that I just spoke to. We need these things to happen now, and we are asking for swift action. This is not a time for deliberating. We are working hard, really hard, to get life-saving care to patients who need it most. Western Washington is experiencing the worst of the surge at the moment, but we expect to see upticks in Eastern Washington cases soon. Our hospitals have made a commitment to one another to level load across the system, and the Washington Medical Coordination Center is doing this actively with the hospitals, and right now is reserving movement of patients for those who are most in need of life-saving care. I want to emphasize that we are not yet at the point where crisis standards of care have been declared by the state. In Washington state, crisis standards are triggered when we need to ration specific scarce resources like ventilators or ICU beds among patients who need them. This is a state level decision, not one for individual hospitals. We are, however, using contingency and crisis staffing models routinely at hospitals in Western Washington. This does not require action by the state. When we are doing this, it means that we are deviating from our normal staffing patterns due to a lack of available staff or rapid or unexpected increase in demand for services, or both. Hospitals operating at these levels will be taking a number of steps to make sure all patients who need care can receive it. It may mean that patients experience longer times waiting for care, that some services are not offered, and that includes routine COVID testing that's not a part of a hospital stay. Care teams may be caring for more patients than is normal, and staff exposed to COVID-19 or who were previously infected may return to work sooner than normal. However, hospitals operating in contingency and crisis staffing will also be following Washington State Department of Health and Centers for Disease Control and Prevention guidance for this method of staffing, and will take additional steps to keep staff and patients safe. These include additional testing of healthcare workers for COVID-19, immediately sending any staff member who tests positive home, ensuring eligible staff are fully vaccinated for COVID-19, offering boosters doses to all staff, and ensuring that all staff wear masks or respirators and other personal protective equipment that's appropriate for the patient care area at all times. So with that as background, we have some specific requests for assistance from the public at this time. People who just need COVID-19 testing or who are not very ill should not be going to the emergency department for care. This includes seeking COVID-19 therapeutics unless people are having life-threatening symptoms. Please stay away from the hospital emergency department and discuss treatment options with primary care providers or an urgent care setting. We strongly encourage folks to get vaccinated and boosted. The sizable majority of hospital COVID patients are not vaccinated or they have only one shot, and very, very few are boosted. Non-vaccinated citizens are 2 to 6 times more likely to contract COVID-19, and they are also 10 to 14 times more likely to be hospitalized compared to those who are vaccinated. Whenever possible, avoid gatherings with those outside your immediately family or your pod of people, especially if you're going to be indoors and unmasked. And please wear a medical face mask when in public, especially indoors. It's time to stop using cloth masks and start using medical masks. So that's it for my comments. As I said, we have some really great panelists with us today who can share more about what's happening on the ground. I want to go ahead and start with Dr. Waco. And Dr. Waco, I can't hear you. Are you unmuted?
How about now?
Now I can hear you. Thanks.
Okay, great. Well, thank you, Taya, and good morning. And thank you to Washington State Hospital Association for gathering us here today. I'm Dr. Elizabeth Waco. I'm the Chief Exec for Swedish Seattle. So we've had a record number of COVID-19 cases in the Puget Sound. And just Tuesday, King County saw a 97% increase in COVID-19 cases. And we've seen a 94% increase in hospitalizations in the past 7 days. So at Swedish, our cases are up over 5 times what we were in December. So that's a lot. We know that Omicron is highly transmissible, and it is the dominant strain of COVID-19 that we're seeing right now in the nation. And if we look at the data from South Africa, the science is really showing us that this will likely peak at the end of January. So while we may have a few more weeks left in this surge, we do know how to tackle this problem. Like Taya said, being vaccinated and boosted works. Vaccines help protect you and your loved ones against severe disease, and in most cases, hospitalizations. So right now, 22% of the patients in our ICU have COVID-19. And of those patients, 62% are not vaccinated. So we're asking the public, please, if you can, get vaccinated or get your booster shot. It really makes a difference. So we want you to know that continuing to take precautions really works. So if you're symptomatic, meaning you have symptoms, you should get tested. Quarantine if you're symptomatic or you're exposed to someone who's tested positive for COVID-19. You should keep wearing masks, you should continue social distancing, and then follow your local public health guidance for safely gathering. If you take these measures, that will help protect you and your loved ones and our healthcare system. So while we know that we've got this, we've been here before, there are some pain points that are straining our healthcare system and our teams right now. And probably one of the biggest pain points is we just have a math problem. With Omicron surging in the Puget Sound and more people coming into our hospitals for help, at the same time, Omicron is not really discerning between a healthcare worker and you. So we've been hit hard with healthcare workers who are out sick, and it makes it very difficult to care for the influx of patients that are coming in who need our help. So to manage that, we've had to make some pretty difficult choices around surgeries, and we've reduced our surgical capacity around 40%. We're doing all we can to continue to provide high quality care for our community. And we're utilizing agency staff, including nurses, if necessary. And we're considering updating the guidelines of the CDC to getting our caregivers back to work as safely and quickly as possible. So I do want you to know that our partners in the community and many of those of us who are on the call today, we are monitoring this situation minute by minute. And we do have it. And it's really important that we're going to make it through this surge. And to do that, we're going to need a little bit of help from you. So get vaccinated or boosted, get tested, but please avoid the emergency department for testing. You should look to find a site near you, and you can go to the government website to find that. Mask up. And finally, please be kind to your local healthcare worker. We're doing our best to care for you and our community. Thank you.
Thank you very much, Dr. Waco. Thank you very much, Dr. Waco. Okay, from here, we're going to go to Reza Khalil.
Hey, good morning, everybody. And thanks, Taya and Dr. Waco for your comments. I would certainly agree with and echo all of what was said there. I'll share a few comments specific to our part of the state and Kadlec of what we're seeing. And really, with all of those dynamics that were described, we're trying to balance essentially two things. One is our obligation to provide access to the community for care that's needed at any time, whether it's during a pandemic or otherwise, with our obligations also to make sure that that care is provided at a high quality, that it's provided in a safe manner, and that, quite honestly, our caregivers are kept safe during that. So as we go through this surge currently, I think each day looks a little bit different, and there are many variables through this, as everybody knows, and some of them look a little bit different with this Omicron surge. So good news and bad news, again, to echo some of Dr. Waco's comments, the good news, I think, with the Omicron variant has been we are not seeing as much severe disease as a result of COVID coming into the hospital. So as an example, we have yesterday admitted about 14 patients with COVID. The majority of those 14 patients were admitted really for other primary reasons. They also happen to have COVID. versus during the Delta surge. When we look back, most of the patients that were admitted with a primary reason and underlying cause of COVID that needed to be treated. So the severity of disease seems to be less, as you're hearing nationally, and our numbers here are playing that out. I think the bigger challenge for us now has been just with how contagious this is, and as was mentioned, the amount of staff that are catching it or suspect they've caught it. And now as we're trying to adjust to the new CDC guidelines and all the twists and turns and be compliant with what's required and keep everyone safe while also being as reasonable as possible and getting people back to work so we can stay staffed. We are, as was said earlier, in a much more challenging situation than we have been in other surges due to those resources. There have been some supply chain issues also in the past and back in 2020. Obviously, PPE was the big point of discussion. And when we were talking about things like canceling surgeries and doing other things, part of it was PPE conservation. And that's no longer a challenge for us. But other things now that have come up due to changes with availability and supply chain and the economy have become challenging, whether it's things coming out of our pharmacy or most recently blood supply has been very short. And so trying to work through some of that. So very different situation from that standpoint. And then I think lastly, I'll say, I think the variables have become so nuanced, whether it's masking or testing or so many things, there are not simple answers that we can provide to people. So when you ask, do I wear a cloth mask or a paper mask? Well, is it a surgical paper mask? Is it a N95 mask? Is it a counterfeit N95 mask? Or is it a real one? Are you double masking using a cloth mask on top of a paper mask? Does your cloth mask have a filter in it? So all of these different things, and you've all heard a lot of the nuances regarding testing now between PCR testing and antigen testing and some of those other things. So the challenge for us has been trying to manage all of these complex variables and all of the nuances within each while trying to provide simple guidance to the community. So I really appreciate Taya's very simple guidance earlier on today to really stay away from our emergency departments as a testing resource. If you're just looking for testing and you aren't ill and needing medical support in that way, we're having still a number of folks coming to our emergency department here just looking for testing, and there are other testing resources in the community. The emergency department tends to be the area that gets hit the hardest when there's not enough staff to make sure we have beds available. These are the folks that are having to hold patients in that ER until there is a place to move them to. And then further down the stream, once you get folks admitted into a bed, as was discussed earlier, if we don't have a place to discharge them to, whether it's back to home or back to a skilled nursing facility or somewhere else, we end up with patients sitting in the hospital that don't need to be here, that we're trying to move out. So just encouraging the public and the community to do everything they can to help us over the next few weeks. As Dr. Waco said, the epidemiology of this seems to be that it's going to burn out over the next few weeks. We don't know that for sure, but Eastern Washington's a little bit behind the western side of the state. So we're at the beginning of our surge now. We will probably peak a little bit later than what we're seeing on Western Washington. So we're buckling down for a pretty challenging few weeks, but with great hope that we will see this kind of move through and on to better days. So thank you for being with us this morning.
Thank you so much. And if folks have questions, please go ahead and type them into the chat. We'll get to them after we hear from our panelists, and we'll also have some time if you want to go ahead and take yourself off mute and ask questions a little bit later. But I want to go ahead and move to our next panelist, and that is Christina Wager.
Hi, everyone. I am Chris Wager. I am the Chief Operating Officer at Newport Hospital and Health Services. We are a rural critical access healthcare organization located about 40 miles north of Spokane, and we are right on the Idaho border. So a lot of what I'm going to talk about today is from the rural perspective, but it mirrors a lot of what everyone else is hearing. So for the state of our organization, we are just like the rest of Eastern Washington, where currently we have not seen a large increase in hospitalized COVID patients. We still have some, but we haven't seen a crush of it yet. However, our COVID positive case numbers and percentages have risen dramatically over the last 2 weeks, and I don't believe we're quite done with that yet. We've probably tripled, quadrupled over the last 2 weeks in terms of COVID numbers in our community. We're definitely seeing ER, our emergency department, back up a little bit. So we're definitely seeing those ER borders where we're unable to transfer, or we have in our acute care hospital, we're seeing difficult to discharge patients. And when our tertiary care facilities, when Spokane backs up or when Western Washington backs up, the congestion hits all the way back up to us. And you know, there are obviously quite a number of services that we can provide, even though we may not have provided them before. I will say that our medical staff and our nursing staff have been absolutely amazing in taking all of this in stride and learning what they can do and rapid fire doing education and utilizing resources to help us through intensivist care and ventilation and all of those factors. So they've been really amazing with just doing what we can for our community. And that's always the resilience that you see in a rural community. And that's what we've always had to do. That said, we're seeing the same amount of staffing challenges that everyone has been seeing. We have a number of open positions. We have a lot of sick employees, so they're out. We have a lot of people who are just burned out. We're, you know, honestly, I think the term is emotional exhaustion. We are all, from our lab to environmental services to our front desk to our nurses, very tired of what we're seeing. And here we go with another peak. And so it becomes very taxing on those people who are still left. The other thing that's interesting in a rural community is that we definitely have lower vaccination rates than our urban counterparts. And a lot more reluctance to those mitigation strategies that we know can work. So there's less masking, there's less vaccination, there's resistance to antiviral medications, which all plays a part in what we may see. I am hopeful that I hear that maybe the peak has been reached in Western Washington. I've been reading the news about the East Coast, and they seem to be over the peak and heading downward just as quickly as other areas of the world have seen with Omicron. So I'm hopeful that Washington will see the same thing. But again, we're just trying to be cautiously optimistic and still continue to keep everyone's spirits as high as we can, support them in any way that we can, and just get through this all together for the best of our community.
Thanks very much, Chris. And like you, hope that we are gonna be near the peak soon and start heading down the other side. Okay, want to turn next to Dr. John McGuire.
Hello and good morning. Yeah, I'm John McGuire. I'm the Chief of Critical Care at Seattle Children's and one of the medical directors here. I'd like to give an update. First, thank you for the opportunity to be with you all this morning. I'd like to give an update on kind of the pediatric situation here in Western Washington. Similar to our general and adult hospital counterparts, we are seeing unprecedented high numbers of positive cases of COVID, higher rates of positive tests. Fortunately, the impact on our inpatient situation isn't too bad. We have the highest number of positive inpatients that we've had, but most of these kids are coming in for other reasons, not COVID. And the kids who are being hospitalized with primary COVID disease are kids with underlying health conditions and comorbidities that increase their risk. We have not yet had to have a child on a ventilator with the Omicron variant, and we hope that that continues. We are concerned that there is a risk of seeing some more MISC in the coming weeks. Typically, we see the multi-system inflammatory syndrome in children rising 3 to 4 weeks after the peak of COVID in the community. So with this timeline that we've been on with this rapid surge, we may still yet see some MISC. So the major impacts on our pediatric hospital right now are real high numbers of COVID cases, surging visits to our emergency department and our urgent cares. Like the other hospitals, we encourage families to not bring their child to the emergency department or urgent care for the purpose of testing. We are short on testing reagents, both for PCR and antigen testing, so we're trying to limit the use of our testing for patients who really need it. And like the other hospitals, we're having significant impact on our workforce. In all roles, we've been impacted by COVID exposure and infections, and that has really reduced our workforce. And overall, we're hopeful that if we can get to the peak, that we'll weather this without too much serious disease in children. There does seem to be much milder Omicron disease than in the Delta wave, where we saw significantly higher numbers of high acuity illness. So to summarize, high numbers of cases, most kids hospitalized, not primarily for COVID, but incidental positive, very large numbers of patients coming to our outpatient settings, and significant impact on our workforce. Thank you.
Thank you, Dr. McGuire, for those insights into the pediatric world with this Omicron surge. And I want to turn it to our last panelist, who's going to be our panelist closer, Dr. Michael Anderson.
Thank you, Taya, and thank you everyone on the panel for your comments. I really can echo everything that's been said so far. So therefore, I want to try to put some perspective on exactly what everyone's been trying to say. With Virginia Mason Franciscan Health, I represent the 8 hospitals across the Puget Sound area that are providing primarily adult care throughout the Sound. In those hospitals, to include our emergency departments, we have seen an unprecedented tidal wave of patients coming to our facilities, asking for testing, as well as asking for emergency care when there are true emergencies. And so when we look at 1,000% increase in the number of individuals showing up in an emergency department, it truly is a superhero effort to try to find out who is really sick in that crowd and to attend to their illnesses. Because of that, as you see across our system, our emergency departments are absolutely full in their treatment bays, and therefore a lot of our care is being provided in the waiting areas and in additional tents that are spread across the system. That is because, as Taya said, you think of the throughput through the hospital. If we cannot get people out of the hospital to the skilled nursing facilities where they can receive continued rehabilitative care, then the whole system backs up with that. As an example and perspective, we probably currently have just over 100 patients in temporary bed locations across our 8 hospitals right now, waiting for an inpatient stay. We know that they're sick enough to be in a hospital, and we're providing the best care available to them in their temporary bed locations. Most of those are in our emergency departments, just waiting for a bed upstairs. But unfortunately, we have well over 200 patients that are well enough to go to a skilled nursing facility at this time throughout our facilities. But we are unable to get them out the door to those facilities, and therefore we have the backup all the way through our emergency departments. This then leads to the necessary move to take care of and to assess the patients that come to our emergency departments in the waiting areas, because there's no place in the emergency department now to actually see those patients. I'll have to say our physicians, nurses, MAs, our dietary staff, our housekeeping staff, everyone working in the hospital is so creative and innovative. They've been able to take care of patients and take care of things that you would think needs those rooms in the ED, such as gunshot wounds, such as acute heart attacks and things like that. They're having to see them in alternate locations within their facilities, which is not ideal. And therefore, something needs to be done to clear up this backlog. In addition, you've heard about patients coming to facilities just asking for testing. And I'll have to emphasize that we have seen a marked increase in patients that are asymptomatic, have no symptoms whatsoever, but they're sitting in our waiting room saying, I was told I could come to this emergency department to get a test. That is so far from the truth. And as I've mentioned, it's already causing situations that we have not experienced in the recent past during the pandemic or ever during an influenza season. Therefore, I cannot overemphasize, if you are not sick enough to be seen in an emergency department, if you don't think your symptoms are severe enough to be seen in an emergency department, please contact your primary care provider. Please seek out care in an urgent care clinic, although they will not be able to provide that asymptomatic screening either. That's why you should contact your primary care provider or a local run testing center where you can set up appointments. So please help us. Our healthcare providers are the true superheroes of this pandemic. We recognize that early along in the pandemic, but this is like the final exam. It's so hard for them to continue what they're doing right now that burnout is not the good term for it. They are just exhausted. Therefore, please help them by first, not coming to seek a care that is not needed. And number two, if you are not vaccinated, this is a compelling message to say, please help your local healthcare facilities reduce the need for hospitalization by seeking not only vaccination, becoming fully vaccinated, but also being boosted if appropriate. It really does work, and it reduces the need for hospitalization. So that's all I have, Taya.
All right, thank you so much, Dr. Anderson. Really well said. We chose well for our closer. I'm going to turn now to some of the questions that are coming in through the chat. And the first one is from Keith Eldridge, who says he would like to ask a question. So please go ahead and come off mute and let us know what your question is.
Hi, so the governor is actually going to be talking to us a little bit later today, along with the Secretary of Health and General Doherty of the National Guard. What exactly do you need for us to ask of the governor on your behalf that you absolutely need to get the people out of the hospitals into rehabilitative care? What can he do today with perhaps his executive emergency powers that will alleviate the situation for you?
Yes, thank you so much for that question. So there are a few things actually that we have asked for the state's support on that will help to address this particular challenge. One of them is doing the process pieces that will get the patients who are backed up in our hospitals, as you say, into long-term care facilities. So there is a process that the state goes through to assess these patients. We need that process to go much faster. A good description of this is that the process can work for those assessments in days, or excuse me, in weeks and months, and hospitals operate in hours and days. So we need that assessment process to happen much faster. Some of these patients who don't have the ability to make decisions have been identified by the state as needing guardians in order to make the decision to move that patient to long-term care. We have provided the governor's office with a draft of a proclamation that would address this need and be compliant with federal law, that would allow for decision makers who are actually there at the bedside with the patient, who are capable of consenting to major treatments like surgery or even withdrawal of life-sustaining treatment, to be able to consent to long-term care treatment for these patients. Right now, under the current interpretation of the law, those patients that aren't able to make their own decisions need a guardian. So we would really like for that to be changed through emergency powers. We also have a piece of legislation that is going to be before the legislature shortly to address that issue long term. We also have asked the state to immediately deploy staff, whether it's through the National Guard or agency contract, into long-term care facilities to be able to provide the care so that the facilities are well staffed, so that the patients can be cared for in those facilities and not in hospitals. This difficult to discharge patient challenge is one that is multifaceted. It is not simple to solve, but we do know that there are things that can happen immediately to start alleviating the pressures, and those are some of them. if panelists have other solutions that I have not mentioned or missed that they would like to speak to, please go ahead. Okay. Hope that helped answer your question, Keith. I have another question here. This is from Kate Armstrong, who's representing Senator June Robinson. She's wondering if someone could speak to staffing challenges in light of this year's safe staffing bill. So as background, the Washington State Legislature is in session, convened on Monday, and a piece of legislation has been introduced that is targeting staffing in hospitals. And from the Hospital Association perspective, I will just say that we are still in the process of understanding this bill. It is lengthy and it is complicated. It has a lot of different ways that restrict how staff can work. And I want to pause here and just reflect what I think all of our panelists have reflected. Our staff are exhausted. They have been stretched, they have been pushed, they have been taking extraordinary measures to keep delivering care. We need to do all that we can to support them. Hospitals, I know, have been doing this in a number of different ways, you know, whether it's providing extra pay for picking up extra shifts, providing free food, doing, you know, resources for mental health, trying to provide as much wraparound support as possibly can be done. But one of the things that we are concerned about with this bill, even though we're still in the process of understanding it, is that we know it's going to restrict the way that staff are used to serve our patients. And one of the things that we also know about stretching in a surge like this is that we need the maximum flexibility possible. When an emergency is declared, the pieces from government usually are to offer more flexibilities in terms of regulatory structure. And this bill would be imposing more limits and constraints on our ability to stretch staff so that they can serve patients in these really challenging circumstances instead of providing more flexibility. So we're concerned that it is potentially moving in the opposite direction of what we need. As I said, we're still working to understand it. So I don't know if any of our panelists have comments that they would like to make about the prospect of having constraints on how staff are used in hospitals. Okay, no one's taken that one. All right, I'm going to keep us moving here. All right, next question is, how is non-related healthcare being impacted by the current surge? Has WSHA had any conversations with the state in the last week about expediting the discharge process for the patients who no longer need to be in the hospital? Any changes planned currently? So I think I spoke to the difficult to discharge patients a little bit earlier. I would love to turn to our panelists about how non-related healthcare is being I think this is.
I meant non-COVID related.
Non-COVID care. Yeah, I was guessing this was maybe, you know, folks who are ill with things that aren't COVID or who maybe need a surgery or a procedure or some other hospital-based care. I'm wondering, Dr. Waco, if maybe you want to speak to that one. You talked about the reduction in your surgical volumes.
Thanks, happy to. So yes, if you're coming in for a surgical case and we have a whole multidisciplinary team that looks at our different cases and takes all these factors into consideration to decide which cases will allow to move into our operating rooms or our procedural suites. So that is how we're getting to the 40% reduction in surgery. So there are things that normally would have happened in the hospital, care that we would have normally delivered that we're simply unable to at this time. The criteria we use is anything that could be delayed for up to 90 days. It's taken actually a big toll on the hospital to be able to assess every single case that comes in and make a judgment about that. But really, it's our only way to get additional staff to the hospital. If you think about it, it's a channel moving through the hospital. There's only 3 ways you can affect it. You can affect it coming into the hospital, which is how and why we've asked people to be vaccinated. We've asked people to isolate. We've asked people to use their best judgment and to follow our policies around social distancing. It's those managing those staff that we have in the hospital. And with the staff we have in the hospital, the only way we can increase staff is by reducing surgical cases, reducing the number of patients that we bring into the hospital, utilizing those staff in different ways in the hospital to care for the patients that we have. And that's, like I said, an even more significant problem this time around because our staff are getting sick now. And that's reduced the number of staff. And then the other way is the exit of the hospital. And this is where we're partnering with our governor around support around governorship. So making decisions about placement for your loved ones when they're in the hospital, allowing caregivers to ask the family members that are with the patient to help place them. It's around providing support to the nursing homes and skilled nursing facilities so that they'll be able to take our patients. So essentially, those are our only avenues to try and manage through the crisis.
Thank you very much, Dr. Wicko, and thank you, Ariel, for your question. Next question here is from Grace Madigan, and this is, Bloodworks Northwest issued a code red for the whole nation, and the whole nation is seeing a shortage in blood supply, partially due to the number of COVID cases taking away potential donors. They wanted to ask 2 questions. What happens when a hospital runs out of blood? What are the steps from there? What would it take for our local hospitals to get to that point from where we are now? And so I want to ask our panelists what things are like on the ground there, if you're experiencing blood shortages to the level that seems to be described here and how they're being managed.
So we are experiencing critical blood shortages. We have made continual public announcement messages to please donate blood if you're feeling well. We've asked the same for our caregivers. How that affects that. So right now we have enough blood supply to care for the patients we have. Why we're worried about it is we don't want to be in a position where we have a patient that's bleeding and we're unable to transfuse that patient. So so if you want to know what happens when a hospital runs out of blood, so as an anesthesiologist, I can tell you what happens when a hospital runs out of blood. You start to use alternative measures to replace blood and alternative products. They are nowhere near as effective as blood. And you know, the need of blood is very emergent, and it can happen in very many settings. It can happen in labor and delivery. It can happen in the emergency room under trauma. So it's not just in the operating rooms where you see the need for blood. So I would second our messaging from Bloodworks Northwest that if you are capable of donating blood, if you feel well, I would encourage you to please donate blood.
And this is Dr. Anderson. I have to echo Dr. Waco's comments in that, yes, throughout our system, we have seen some declines in the availability of blood. And when that happens, we start putting a second review of the cases that we take to the OR to reduce or mitigate the potential risk there. And when a community runs low on blood, it truly is a community problem. As Dr. Waco said, we ask our own staff to go out and donate because they understand how big the problem is. And when you're exhausted and you're also literally giving blood, that just makes the situation worse. So the appeal has to go out to the communities that surround our facilities. For those that are feeling well and know that they can donate blood, please contact Northwest Bloodworks Northwest to see how you can help.
All right. Thank you, Dr. Anderson and Dr. Waco. Okay, so this is a question from Cairo Radio, who says, yesterday, Chiro Radio learned yesterday that MultiCare is sending staffers with COVID symptoms back to work as long as they are fever-free. They're told to first work with COVID positive patients, then vaccinated patients, and not at all with immune compromised. Can you clarify what immune compromised mean? Even if a patient is not specifically immunocompromised, how can COVID positive staffers be kept from infecting people who are weak enough to be in a hospital and recovering from a major health ordeal? People who are vaccinated could still be infected, especially if not boosted. And couldn't someone with COVID be infected with a second variant at the same time? So we do not have a panelist for MultiCare on. However, this gets to the topic that I raised during my remarks, which is that we do have hospitals that are operating at contingency and crisis staffing levels. And the reason for this is that hospitals are really balancing the need to actually get care to the bedside with the fact that, you know, we need to be as safe as we possibly can in delivering that care. And so that care is being delivered using very specific guidance from the Washington State Department of Health and the US Centers for Disease Control. And one of the things that I talked about are the ways that we make sure that staff are as safe as they possibly can be in going to the bedside. And if I want to be clear that when staff test positive, staff are in these models still sent home. The question is how quickly they return to the bedside to work. And so when they return to the bedside to work, they do that per those protocols. And yes, they are assigned to work in areas with patients that will be as safe as an environment, given that the staff member has returned to work from having had a COVID case. And so that means that if somebody who has had COVID is back at work, the first place that they will be working is with patients who have tested COVID positive. I will leave it to our doctors to be able to speak to what immune compromised means. And I'm wondering if maybe Dr. McGuire could speak to the topic of being immune compromised and how that is affected by having what that means relative to those who are not.
Sure. Immune compromised is a pretty broad term. It could encompass patients who are receiving therapies that specifically affect their immune system, such as chemotherapy or immune modulatory drugs that might be used for diseases like lupus or rheumatoid arthritis or other autoimmune disease. Steroid therapy is immunosuppressive and could create an immunocompromised state. There may be people who are recovering from severe illness whose immune systems haven't fully recovered. So I think it's a broad term. In the hospital setting, it is most likely applied to, or most commonly applied to, patients whose disease conditions or therapies that they're receiving specifically affect the ability to respond to infections. So it's a broad term that would have to have kind of individual patient circumstances. But that's the risk factor for more severe illness with COVID, certainly.
Right. Thank you very much. I know we've got a number of additional questions coming in here. So I am looking to see, at this point, do we expect to be able to get through this Omicron surge without formal declaration of crisis standards of care? What kind of discussions are you having with state officials about potential declaration? So I can just offer that we are having a lot of conversations with our state partners. So we have been talking to them nearly daily over the last several days. And at this time, crisis standards of care is not something that is imminently on the table. However, as I described, we are at these levels of crisis staffing just to make sure that we are able to keep staff working at the bedside, again, being as safe as we possibly can. So we, as I said, have been working with state partners to identify all the possible levers that can be pulled. And you may hear more from the governor about that this afternoon, about actions that they're prepared to take in terms of deploying more resources, whether that's from the National Guard or staffing agencies, or making adjustments in, you know, how the state is getting these patients who can't make their own decisions, the consent that they need to move into long-term care. So I'm hoping that we will have some more news from the state this afternoon about what levers they're able to pull, and do want to make sure, even as we're pressing and trying to really encourage action, that we also thank our folks at the state for working with us in partnership, because we need those resources. We can't do this without them, and they have very much to their credit been there with us in dialogue, even as we face this incredible challenge before us. Let me just see what other questions we've got. What percentage of patients are in the category of no longer needing to be there that can't get placed into rehabilitative care, long-term care? So I will turn to our panelists who might be in possession of percentages for their own facilities. I can say that on a statewide basis, it is literally hundreds of patients. So any of our panelists want to speak to what things look like in their own facilities right now?
Yeah, I can speak to Swedish, the system. So at Swedish, I would say 10 to 15% of our patients. If you think about it, it's probably 3/4 of patients that are non-medical need to be in the hospital. This is a large amount.
Any other panelists? Yeah, go ahead.
I can speak on average. I mean, we see around that 10% mark, but you know, you see these surges and things, and the number moves with what's going on in the rest of the community. So it's, you know, we in hospitals, there's a term, avoidable hospital days. So we tend to look at, you know, what we call avoidable days, meaning days in the hospital in aggregate that people could have been discharged to a more appropriate setting. And so whether that's to rehabilitative care, as the question was, or to some other setting that's not the hospital, we look at all of
that. Chris at Newport, same thing for us. Again, being rural, we've always struggled with this a little bit because we don't have a lot of resources in our own area. So, you know, we have to look at, you know, Spokane and even into Idaho sometimes for placements. And everybody is, again, as I think the word I mentioned earlier was congested. And then there's also the legal ramifications. So again, we talked about this earlier, and Taya spoke about, you know, the guardian ad litem process and DSHS. Again, in a rural community, many of our community members are, you know, under the poverty limits. They don't have the money to private pay into some of these skilled nursing facilities or rehabilitation care. Sometimes their insurance doesn't quite cover what they need to cover. Sometimes they do need to be placed in longer care than just rehabilitative care. Family members are also, you know, not able to care for these patients. And so we just have seemingly risen in terms of how complex it is and the number of patients that we're seeing that are in those circumstances. So it's been challenging.
Yeah, I do want to provide some clarification. The question was specifically about rehabilitative care, but the 10 to 15% really refers to non-medical necessity patients. So those are patients that need home health. Those are patients that need skilled nursing facilities, adult family homes. So it's rehab. So it's the entire category, not just rehabilitative care.
Great. Thank you for the clarification. Okay. We have just a couple minutes left. We have another question about the staffing bill and how it would restrict staff flexibility, and also a question about the fact that there have been a record number of workplace safety complaints this year, and solutions and guidance that WSHA can offer. So I will say it has been an extraordinary time in healthcare, and we have not been providing care under normal circumstances. Earlier in the pandemic, for example, we were very stretched for personal protective equipment. We have been stretched for staff. We have been stretched for other resources like beds. We just talked about this challenge with difficult to discharge patients. And so, yes, compared to normal times of providing care, we haven't been operating in normal circumstances. And so to that end, it's maybe not surprising that staff are expressing concerns. I do, though, want our panelists to have an opportunity to speak to the ways in which they have been supporting staff, because I know that hospitals have been doing a lot in this area to try and support staff. Staff are, of course, the backbone of the entire operation. It's the whole point of healthcare is to have people helping people. And so if any of our panelists want to speak to the various ways in which they're supporting staff, I would really invite them to do that.
Well, this is Dr. Anderson. We appreciate all the work that our staff are doing, especially when they go above and beyond during this situation that we see right now. It is difficult to find some of the traditional ways that we help support the morale and well-being of our staff, in that some of the traditional things that we might have as social gatherings, picnics, and things like that, we can't do that because of the pandemic. So we have been creative in finding ways to bring in mobile food trucks and provide free meals for the staff. We've also occasionally have been providing bonuses for the staffs that have worked here as well. But again, things are challenging, and we really have to be creative on how we support our staff.
And so I agree. I think Dr. Anderson, that was well said. It's incredibly challenging. I mean, historically, we would have, how we show love is by food, and we would give you food. And so it would be a gathering, it would be a picnic, it would be a potluck. And those are things that we simply can't do anymore. So for Swedish as an organization, we've been really focusing on mental health and wellness. We've provided many mental health resources, online resources for family members. It's hard to come to work when your family is sick. So how can we support your family? We've provided free COVID care for our caregivers. We've also provided child care and elder care for our caregivers to allow them the ability to be able to come in and work and relieve that stress. We've also done the bonuses also, not all things can be treated financially, but it does help.
Great, thank you very much, appreciate that. And one last comment I'll just make with respect to the bill. As I said, we are still understanding this piece of legislation. It is incredibly complicated. There's a lot to it. One of the things we do know is in it are certain ratios of staff to patients. And we are very concerned about the potential of that type of restriction to mean that some patients simply won't be able to get the care that they need. There's only one state in the nation, at least that I know of, that has mandated ratios, and that is California. We know that they're experiencing a nurse staffing shortage that is worse than we are experiencing here in Washington State, with patient outcomes and staff satisfaction levels that are actually Washington State does better in both areas. So we are, as I said, really concerned about the potential for mandated ratios to mean some people just won't get the care they need, and at the same time won't achieve some of the potential goals of those of that type of measure. So I think other states have looked at the California model and decided that the risks of implementing something like that just don't aren't outweighed by the potential benefits. So I am going to go ahead and close this up. We are now a little bit past time. I want to say a huge thank you to our panelists and also to everyone who joined us today. Thank you for helping us get these messages out to the community, and we will be back again, I believe, next week. Thank you, everyone.